Welcome to today's webinar, Pediatric Life Care Planning, Best Practices for Life Care Planning and Care for Children of All Ages. This webinar is hosted by Medical and Life Care Consulting Services, a case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is Gigi Liggins, and I'm the moderator for today's webinar. This webinar is anticipated to run about 50 minutes, with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the duration of the webinar, and we do ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. You can also chat if you're having any issues with technology. Post-webinar, we will share a link to the recording along with a short survey we ask that you complete. We're excited to host today's webinar and certainly look forward to an opportunity to work with you. I'd like to start by introducing today's presenter and founder of Medical and Life Care Consulting, Cynthia Bourbeau. Cynthia Bourbeau is the president and founder of Medical and Life Care Consulting Services and has worked as a Massachusetts registered nurse, certified rehabilitation nurse, certified nurse case manager, and certified nurse life care planner for over 3 decades. Founded in 2001, Medical and Life Care Consulting, often referred to as MLCC, provides life care planning, Medicare set-aside, legal nurse consulting, and more throughout the United States and internationally. We also provide case management services throughout the Northeast region of the United States and a wide range of care consultation for catastrophic injuries and fiduciary support post-injury and settlement. Cynthia is a member of the Association of Rehabilitation Nurses, the American Association of Nurse Life Care Planners, the International Association of Rehabilitation Professionals, and the Case Management Society of America. She is also a board member of the Certified Nurse Life Care Planner Certification Board. Cindy, the audience is yours.
Thank you, and thanks everybody for joining us today. I always enjoy talking about life care plans, but especially pediatric life care plans. They're a very thoughtful process that we go through in preparing these plans, and it's a joy to get to know the children a little bit. So our agenda for today is life care planning and the life care plan, understanding the injury and medical treatment to date, fully uncovering the present status of the child and implications for the case, incorporating treatment recommendations and estimated future expenses, understanding the school years and their implications for the plan, addressing growing bodies and changing needs and aging through the developmental stages and beyond, and accurate planning of costs. So it occurred to me, as I was trying to just focus on pediatric life care planning, that some of you may not even know what a life care plan is. So this is, a life care planning is a specialized area of the nursing practice that deals with catastrophic injury or illness. And a life care plan is a tool that's used for estimating the treatment needs and costs of that care over a client's or patient's estimated lifespan. And it's a very comprehensive report that contains a summary of the patient's medical status, his treatment, and then an outline of where the patient is presently, and then the treatment recommendations that are recommended for his care. And we're going to see a little bit of that today. So who asks for pediatric life care plans? And just like any other life care plan, it can be plaintiff attorneys or defense attorneys, insurance carriers, divorce and family law attorneys sometimes ask for them, and estate planners, advocacy groups, rehabilitation centers, and even patients and clients. I get a lot of calls from families who are struggling with a child with disabilities to see what they can anticipate for the future. So there are a lot of reasons for a pediatric life care plan. There are a lot of diagnoses that go along with it. When you talk about pediatrics, the focus is usually on birth injuries. However, there are many different diagnoses that you can be addressing with a pediatric life care plan. And they're as varied as plans for adults. However, some of the most frequently seen diagnoses, and these are just a few of them, are hypoxic ischemic encephalopathy, strokes, global developmental delay, spastic quadriplegia, hemorrhagic hydrocephalus, or subdural hematomas of any kind, blindness, cortical visual impairment, cerebral palsy, dysphagia, hypotonia. There are many diagnoses, in addition to everything that you would see as an adult also with adult injuries. So the Pediatric Life Care Plan is the development of a treatment plan to promote the restoration and then maintenance of health. It looks at the entire child, not just the disease or the injury, but its effects on all body systems and aspects of his or her life. And as a nurse, we use the nursing process to formulate a plan of care to identify the child's individual needs. And so we go through the assessment, diagnosis, implementation of the plan, and evaluation. And that's what's every time we meet a patient. So understanding the injury and medical treatments to date is done through many different approaches. The first is chronological review of records, and this could include, but is not limited to, medical records from birth or from the date of injury and at least 2 years prior to the injury if it's an older child. School records could include early intervention or IEP records. And there's also records and billing documents from all the vendors regarding supplies and services. We also review depositions and videos and expert witness reports. And then we interview the patient and the family and friends and do a nursing assessment of the patient and an observation of their living situation. We do an evaluation of all treatments and their outcomes, and communicate with treating providers, expert witnesses, and caregivers to finalize a plan. We review information and complete data analysis. And the data that's collected may include physical, psychological, cognitive, functional development, sociocultural, spiritual, economic, and or lifestyle information about the client or patient. I struggle between client and patient, and I apologize for that, but I do many things in my job, so you'll be seeing me do that throughout this talk. Now, uncovering present status. There is a certain methodology that is implemented by life care planners, and there are certain steps that we do throughout our plans. And so present status is one area where we discuss body systems and what the patient's status is regarding that specific area. So when you're discussing each body system and function and their effect on the patient's life, this area of the life care plan, especially for children, should reflect their status prior to the injury, how it affected their developmental status, and where they are at present. I'm really careful to include all the changes and evolution of their development as I do this. So just a very tiny example would be like vision. If you would have a child that was born healthy and had no real medical problems and then went in to have a procedure and came out with injuries such as brain hemorrhage and hemiplegia, for just 2 diagnoses. These diagnoses could affect the patient's cognitive abilities, their communication, gross motor, and fine motor function. Pre-injury, when discussing vision, the patient could have had a full normal vision, 20/20, both eyes. Post-injury, the patient's cognition was impaired and he might be manifesting problems with intellectual disability. testing showed that his vision was good, but that he had weakened eye muscles that resulted in double vision and strabismus and maybe some nystagmus. And all these are related to the diagnoses, that the underlying problem. All of these things can lead to impaired perception of the child's environment by the child. However, it's difficult to ascertain what that child is actually seeing and absorbing. Some interacting well with their environment. And however, through further testing and evaluation, they may also have something like a cortical visual impairment, where there is a decreased visual response due to neurological problems in their brain that affect the visual part of the brain. All of these diagnoses are important to take into account when you're determining the patient's future needs. And this really needs to be done in every body system that are affected on the patient. So if you have a child with a focus problem, that's just one body part, maybe just a shoulder dystocia, and now there's paralysis of that arm, that's a very focused problem. The cognitive, there may be no cognitive impairments, just functional impairment, and so your statuses would be focused to address those problems. You would be outlining those areas. Now, the next section of a life care plan is incorporating the treatment recommendations and identifying what they are. So when you're dealing with an adult post-injury is going to be where they are. Not every injury or diagnosis is static, but for the most part, adults get to a certain point, they progress, and then they plateau in their progression. And it's pretty static at that point. But with a child, there is no way to know with 100% predictability when you're seeing the child early in their development. So you can predict by how they met their developmental milestones, but if the child is very young, there are all kinds of scenarios that can occur. And I've had some patients that were referred that were like a year and a half old, which is really early in the whole developmental years. During the patient's growth and development years, it's important to facilitate, at least in my practice, maximum medical improvement so that the patient reaches the best self and life and quality of life. In addition, treatment varies with different ages of development. So your life care plan has to reflect the changes that may be needed during different years. And so some of these areas for treatment recommendations that we do are therapeutic evaluations. These are very routine with every life care plan, therapeutic modalities, future medical treatment, doctor's appointments, diagnostic testing and lab work, durable medical equipment that they need, maybe aids for independent communication. And these treatment recommendations will be very individual to each individual patient. I love that picture. So talking about treatment recommendations again, other areas that we deal with are the ones that are listed here. So in regards to medications, obviously the patient that's 5 years old or 3 years old is not going to have the same medications as an adult. But I use a variety of medications that they're on as a child as a basis for what they will have as an adult. That is, they're on anti-seizure medication. If they are on it as a child, more than likely they will be on it as an adult. If they have surgery scheduled, they will need pain medication post-op or other medications. And I include these for any of the procedures. So medications are pretty much based on what they are with the last available medical record that is supplied to you, or your interaction with the family, and you get, the list of the medications they're on. Home care services change along with the patient's age. A 2-year-old or a 4-year-old is obviously going to be managed by their parents for most, and they're manually lifting them still. However, by the time that child gets to be 8 or 9 years old, they're getting too big to carry, and so lifting equipment needs to be added, for example, to a plan, and additional assistance needs to be completed for care for the patient in the home in the morning or in the evening, depending on what's going on with their diagnosis. So it really does change as the patients age. And then you have to also look at what is happening to the parents as the child grows. So this is in regards to facility care also. How old are the parents? If you have parents that had children late in life, which could be 40s, anytime during the 40s, at what age does it get to be too much to be able to do things manually for an adult-sized child in the home? So, you know, kids get to be teenage years and they're fully grown. And so then you have a disabled child who's 6 feet tall and weighing 180 pounds. So you have to take that into consideration. And what will you do if the parents are no longer able to care for their child because they have health reasons or they have something that happened to them? All of these things are considered when you're deciding whether the patient needs facility care or more home care or whichever. And then transportation. If you have a child that at age 5 has mild cerebral palsy and may be a functional ambulator for short distances, their impairments may be primarily lower extremities, so they could have hand controls for their car when they get older and they're able to drive. So you'd want to be able to put those kind of things into the plan and a driving evaluation and maybe some driving education in there. Or if a child is wheelchair bound, you want that child to be able to be with their family everywhere they go. Even a child with moderate CP that can ambulate with assistance to the bathroom may be not able to get in and out of a car consistently and may need a van for transportation. So their wheelchairs may be their primary seating. If a family is unable to care for a child at home and they need to be in a residential home, you know, the residential home can transport them to activities, but how does that family still be able to include that child in weekly events with the family? So a van would be necessary in that case. You have to get to know the families and the patient as well as you can to prepare for every eventuality. And then the last section there is architectural modifications, and these are also necessary for most families with a disabled child. And it always amazes me how people adapt and compensate for what they don't have. They figure out how to make it happen. But modifications can be ramps to full house renovations if the child has the ability to move, to live independently in the future. Next screen. And then the last two areas that I'm talking about here is orthotics and prosthetics and surgical and medical procedures. These areas are usually very clear-cut on what a child needs. Children grow and need constant adjustment and fabrication of appropriate supports. So frequent types of orthotics and prosthetics can be AFOs, KAFOs, Benig vests, various trunk supports, prosthetics, resting hand splints, flexion splints, immobilizers, air casts for tone and spasm, Medipotis boots to prevent contracture, custom shoes or custom orthotic inserts. So there's a variety of splints and braces, and there's really too many to list, but those are some of them. And again, we're dealing with all types of injuries with pediatrics, the same kind of injuries that adults have. So their needs are pretty clear. Surgical and medical procedures depend on the patient's diagnoses, previous surgeries, and potential maintenance surgeries. For example, like if you have hydrocephalus with a shunt placement, you would need to do a replacement every so many years, or baclofen pumps needed for spasm replacements every so many years. G-tube revisions could be necessary, suprapubic catheter insertions later in life for certain problems, colostomy reversals, debridements of wounds and rhizotomies or lysis of nerves, contracture releases. I identify which procedures are reflected in their present treatment plan, which may be identified by the treating physician as probable treatment in the future. So communication with an expert or with a treating physician are key components of getting those items and those procedures listed. And then the last section is educational and vocational needs. So basically, I don't do vocational life care plans. A vocational specialist does that. But, education for children is very important and a very big part of their lives. There are pediatric long-term care facilities that have schools attached to them so they can be cared for medically if they can't be cared for at home. And then their aide or their one-on-one will then take them to the school classroom and be the one-on-one in the classroom. So it's very important. And educational needs are identified through the patient's IEP, independent education plan, the neuropsych evaluations, communication, and specialists such as those from like the Perkins School for the Blind and the school program. All that occurs in schools needs to be carried over into everyday life at home. And whatever treatment that child gets at home should be carried over and continued in the school program. Examples of this would be like a bladder training program where they're toileted every so often at home. That should continue at school. And there should be communication between the school and the home so that everyone's working on the same page. And obviously there are IEP meetings where the families are able to go in and have a conversation about what the goals are for the year and what the treatment's going to be for the patient and the child. Federal programs mandate that children are given what they need in school to be able to participate in school, and all children are entitled to this. And this could include PT, OT, speech, assistive technologies, neurology and neuropsychology evaluations, nursing services for feedings that need to happen during the day and other treatments, one-on-one paraprofessionals. There are vision teachers and teachers for the hearing impaired, etc. There are so many of them. And you'll see in the medical records that all of these therapists are doing their evaluations, coming up with a present status for the patient and goals for the patient and for the team of people taking care of them. All of these services are specifically so that the child can participate and benefit from the school program. In addition to this, additional therapy may be needed in an outpatient or home setting to focus on maximizing the child's development. And usually it is needed because this is their developmental years and you want them to be the best that they can be and be as independent and learn as many skills as possible. And some of these therapies are key to achieving that. If the child goes home and never does the things that are needed to further develop, they will not develop. So children with behavior issues due to autism or intellectual impairment may also need behavioral therapists in the school setting and in the home setting. So the patient may actually do things with their families and have as normal a life as possible. So we talked about anticipating, predicting growth and development. We want to determine how far behind a child is developing. Determining how far behind a child is developing can help you outline where they're going to be in the future. An example of this is if the child is never able to hold up their head, which is really like a two-month-old skill when they're on their tummies to be able to hold up their head. And now they're 5 years old and they still can't hold up their head. You can pretty much anticipate that they'll never be able to be a functional ambulator because what happens with development is babies learn to suck first and then they learn to hold up their head. And when those neck muscles are being used, they then learn how to bring things to center. And all of this there is a sequence of development. And so if one of those sequences, if one of the early sequences are missing, then there could be a problem with any further development in that respect. So let's see. The services that are provided during school years are important to allow a child to have a life and learn and interact with others. But they aren't the only services that they should receive. If you want them to be able to reach maximum medical improvement and enjoy life to whatever level that they can. As I said before, I feel that outpatient services should be added until the patient is no longer progresses through the school years. Outpatient services could be either in the home or actually in an outpatient facility somewhere. Once the child has reached the age of 22, they are then progressed out of the school system, and alternative treatments are available. They could be appropriate for a day program, or if they're high enough functioning, they could be appropriate for a day program with a work program in it and have a job coach who goes to work with them every day, or they could just be in with a group that does work projects. There's all types of supported and non-supported programs depending on their level of capability. When school ends, the goals are still to provide the maximum quality of life for that child. Treatment and care goals are also not ended. So once the child reaches the age of 22 and they're out of the school program, lifelong services are needed post the school years. So consideration has to be made for potential complications and treatments throughout their lifetime to maintain their health and wellness, basically. So I just wanted to touch on school services for children with special needs. This is pre-K to 12 years of age, and children experiencing difficulties in school can have problems such as physical differences, problems with concentration, learning problems, speech problems, language problems, perception and behavior problems. And these can all qualify the child to receive services that you need to take into consideration when you're doing your life care plan. They can be to treat physical disorders, psychiatric problems, emotional problems, behavioral problems, and learning difficulties. So there are school services for children with special needs, and I just wanted to list them here. So children with special needs are entitled to receive additional services or accommodations through the public schools. And federal law mandates that every child receive a free and appropriate education in the least restrictive environment possible. To support their ability to learn in school, there are laws that apply specifically to children with special needs. And these laws cover all programs or activities, private and public. And the laws are listed up here. So you have Individuals with Disabilities Education Act. This is a federal law that governs all special education services for children in the United States. They have to have issues within one of certain categories to be eligible for services. And they are a serious emotional disturbance, a learning difference, an intellectual disability, having had a traumatic brain injury, diagnosed with this, being on the spectrum for autism, vision and hearing impairments, physical disabilities, developmental delays, including speech and language difficulties. Section 504 of the Rehabilitation Act of 1973 is a civil rights statute that requires that the school not discriminate against children with disabilities and provide them with reasonable accommodations. And obviously everyone knows the ADA, and that requires all schools other than those operated by religious organization meet with the needs of children with these differences or disorders. And why did I include these? Because these are all federally mandated and paid for by the government, but it's important that with any child you're doing a plan for, you're aware of these laws and how they are implemented in the state that the child resides. What I do is I research that state and the schools that the child is going to and or are planning to attend, and make sure that all the accommodations are provided and how they provide them. And so these services are federally mandated, and so there's no charge for them in the plan, what they receive at the school. So addressing growing bodies and changing needs. Reviewing all of the items we discussed in this presentation should lead you to a picture of the patient's trajectory for improvement and anticipation of their functional status and needs. An example of milestones missed and achieved would be a child could be impaired and normally should be pulling himself up and standing around 1 year of age. You may have a child that you're doing a life care plan for that may be just turning himself over at that age. However, medical records indicated that by age 4, he is sitting without assistance for a minute. So this shows that he's developing his core strength and overcame some of the hypotonia or the low tone in his trunk, and it developed some strength there and is able to sit up, which is a very good sign. So he's delayed by years, but he was able to strengthen. He may not be a functional ambulator, but is able to turn himself over in his bed, and so doesn't need to be turned at night. And all these details are important in the plan. He missed the normal milestone, but responded to treatment and progressed. Delayed, but he progressed. In addition, let's see, talking about changing size of the child. As the child grows, this is something that affects every status outlined and all the treatment recommendations. So all equipment and treatment needs to address the child's size. And you'll see that in a few examples that I've provided. In addition, also, as children age, depending on what their problem is, their behaviors may also change. And so you have to keep that into consideration. If the child had a head injury or has autism, children with disabilities have hormones also, and as they mature and become teenagers, sometimes these symptoms exacerbate and their behaviors get worse, and it interrupts their normal behaviors until their hormones normalize again and they grow into their bodies. So treatment has to be taken into consideration during that time frame also. Next slide. So one thing as life care planners, what we do all the time is identify in every life care plan what the patient's life expectancy is. Now we identify it, but we don't actually determine it. Children with multiple system injuries, functional impairments, or medical problems can have a decreased life expectancy. Every person that has a life care plan, whether they be a child or an adult, has the ability to have a decreased life expectancy because of medical problems. Obviously, if you have a failing heart or a failing liver, or have a poorly functioning lung, or are not feeding yourself and able to swallow properly because you aspirate, all these things can decrease your life expectancy. So as a life care planner, we collect life expectancy from the National Vital Statistics reports, and there's some tables here for males and females. And these are updated by the CDC regularly. In the event that there is impairment, and I think that it would affect their life expectancy, then I contact an underwriter or an actuary or a life expectancy expert to produce a life expectancy for that child so that I'm as accurate as possible. So these are just some tables that I wanted to share with you just to show you a few examples of what I've been talking about. So one of the areas is projected evaluations that need to be done, and then it would be projected therapeutic modalities, so the therapies that go along with it, but their evaluations are more expensive, so we always list those separately. With impaired patients, there may be different options or scenarios about potential needs due to loss of family or inability of the family to be able to care for the patient in their home. So oftentimes when I do life care plans on children, they include sometimes, there are many options that could be considered, but I usually put 1 to 3 options outlined for the patients. It depends on the specific situation. So I put a few tables into this webinar to demonstrate examples of therapy options throughout the patient's life. But this patient, in this pediatric life care plan, the child needed 2 separate hip surgeries. And it was anticipated that it would be done in the next few years, but could technically be done until age 21, although I doubt that they would wait that long. They shouldn't wait that long, but I put it in for that time period. And OT was provided in the home post-operatively. So what I wanted to show you is, obviously there are multiple therapies that children go through. There's vision therapy, there's feeding therapies, there's PT, OT, speech, there's hippotherapy, there's aquatherapy, There's all different types of treatments that children could need. So what I did was I grabbed occupational therapy through and pulled them out of the plan. So you can see here that those 2 hip surgeries, this child was 2.5 years old, basically, when I met her. And so this shows the post-op therapy that's needed. Could you flip to the next page? So that's post-op in the home. So you have to take into consideration any surgeries that are done for each type of therapy. And then, as I had discussed, occupational therapy is offered in the school system. So we do include that. So you see occupational therapy from age 5 to age 21 in the school program, and there's no cost to plan during that time period. And then you have occupational therapy school summer program. You know, children that have disabilities tend to have poor carryover if they go the whole summer without their services. So you want to be sure that most IEPs will identify that need, and if that child is appropriate, put them in a summer program, which is also no cost to the plan. But again, and that is age 5 to 21. But again, we also talked about therapies that would be needed for further development, because the school system provides what is needed to participate in the school program, but not really long-term goals for this child out in the community. Or, I mean, everybody wants what's best for the child, but therapy is focused a little bit differently. And so there should be carryover. And so oftentimes you see children with outpatient therapy. Now, you could give them therapy every day of the week, but it's not really realistic. That child needs to have a life, and that family needs to have a life also. So you will see here, I put in occupational therapy, either an outpatient or home, from age 5 to 21, 2 evaluations per year. And that's for a 6-week period of therapy. I don't have the actual therapy treatments shown here, but in the next flow chart, it would be on there. And then also with this child's problems, she had a lot of splinting. And so because of that, I also put in 1 visit per year for adjustment of the splinting or braces. And that's for their lifetime. And then once a child ages out of the school system and is now living at home and going to a day program, or living in a residential home, or living on their own, there are complications and exacerbations that can happen because of whatever disability they have, whether it's, you know, they have cerebral palsy and they ambulate, but they have a real antalgic gait. And so their hips are very much affected, their knees are affected. And so all those potential complications are there for the future. And those are usually identified by their treating physicians or indicated in the medical record. And it also, the medical record will also show you consistent complications that they have, like whether it's frequent seizures or whatever. And all of that leads to the determination of how much treatment that they need. So you will see here from age 22 to age 65, potential complications and exacerbations. There were 16 evaluations proposed during that time period. And then aquatic therapy. I think this child also had hippotherapy, and usually that's done in the summer months when it's warmer, and it's usually like an 8-week program in both areas. That's it for that I wanted to point out. But you could see the point of these tables is to show you that you have to take into consideration their size, how old they are, when you're ordering everything. And just another example of that is when children need durable medical equipment and items. Here we've got a custom manual wheelchair that's a pediatric wheelchair to age 16. That number is arbitrary, because you may have a child that's a male that develops early, and by age 13 he's 6 feet tall and needs an adult chair. So you have to take all these things into consideration when you're writing out your plan. Gloves, how many boxes per month, the obvious things. If you want to go to the next page, DME for a child with disabilities can be, 4 pages long because there's a lot of detail in it. This is just a couple of examples. So here, this child, I was anticipating that this child was going to reach a larger size and need a lift at age 8. That's arbitrary also, and it changes according to the patient's size, their bone status. Some children that have a lot of medical problems stay small and don't grow really big. So it's all dependent on that. I think you can turn the page again. And just to qualify all of that, my background is rehabilitation. So my focus, I'm a case manager as well as a life care planner. And so my focus is always to make sure that the plan maintains health, maximum functional status, and independence as much as possible to prevent complications, because the goal is to keep people healthy and out of the hospital and free of complications. And so your plan should reflect that. And I always tell families to ask their attorneys for the plan when they are done with it, and to use it and to follow it. And I know that people do it because I get calls later asking me for clarification about this, and they had trouble with this facility. I just have some sample costs in there that you can see also on this plan. And so they ask questions about it. So families do use them when you're doing pediatric life care plans. I feel most patients find them useful. Next page. Oh, I guess we're done. So
we are transitioning to our question and answer segment. I want to remind attendees to use the Q&A feature in your Zoom chat, and we will read the questions to Cindy and she'll answer. We have a few coming through already. The first one here, I think it's in regards to cost research. And this is where and how do you get your cost?
So costing is a hot topic in the life care planning world right now. I've been doing life care plans for about 21 years now, if not more than that, before they are even called life care plans. Anyways, so where I go now has evolved a little bit. In the old days, I used to just call treatment facilities in that patient's area, and I would get them to give me a quote on whatever treatment I was looking for. And I still do that, but I also include other national sites now because I find that they do the evaluation of the procedure you're asking about or the treatment you're asking about, and they evaluate, 20, 30 different sites in that patient zip code area. So I include that. So we research out costs by making direct phone calls to certain treatment areas where the patient would like to go or is treating. And we also use national databases, and then we get a median of all those costs, or an average if it's all, phone calls. So it varies. And every life care planner is a little bit different on how they do that. But I believe in giving them something that they can use as a resource. So I like to use a couple of costs that are in that patient's area for certain kind of things, because they're going to use it and they're going to call and find out, how they can get what they need and get a better price for it, maybe.
We have another question is, do you project government benefits?
Do I what?
Project government benefits. I think, are they anticipated in the plan?
So I do put all the school federally mandated services in the plan. I believe in giving you a total picture of what that patient needs, whether it's related to the injury or not. When it's related to the injury, I include the cost in there. When it's not related, I put no cost to plan in it. I do not do any, we don't consider whether patients have insurance or any other benefits. That cannot be used in the plan. But these federally mandated school programs are mandated. So yes, those can be included in. And I do.
Okay, thank
if that
you.
answers the question.
I am confirming now, but while I'm confirming, the next question we have is, how do you determine how much treatment to provide a patient?
So there's several ways. I mean, the medical records will give you a history. For example, if you have a patient who is incontinent, who has, let's say, is quadriplegic and is incontinent as a child, and no assistive devices are using. So there's no catheter, no suprapubic or anything like that, but they have this many infections during a time period. Like you're reviewing records and you look back the last 3 to 5 years, if you have them, or however long, you can predict how many urine infections they're going to have because this is what they've been consistently having. So I use that to determine some of those things. I send letters to physicians requesting their opinions on what they feel that is needed in the plan and whether certain things should be identified and what they think they are. So I get in touch with physicians regarding that, or any of their caregivers. So it could be therapists, it could be anybody, and that's working with them. And then also my experience. So I've been a rehabilitation nurse case manager for 40 years. So I have developed opinions about things through my experience. And I think it's probably one of the hardest things to do in a life care plan, because you want to be specific to this patient. They should not be cookie cutter plans where you're just going into a book and writing in every specific item that's in that book that's a potential complication or a specific treatment, because every person is individual, and how it affects one diagnosis, how it affects 3 different people could be 3 different ways.
Awesome. Here's another question about kind of fees for this type of service. Is it usually done hourly or a flat fee?
I think that life care planners all have a different approach on what they do in their own businesses. I think that most of them are paid by an hourly fee, and at least I can't speak for other people, but from what I've seen, I feel that it's usually an hourly fee. And the length of time it takes, just to go a step further with that question, can vary. So if you've got an adult, what I say is, if you've got an adult with a single problem, which they never just have a single problem, no matter what you're told, they never just have a single problem. But if it's a fairly focused problem, and those can be done, depending on the number of medical records, within 30 to 40 hours, right? My goal, I would love it if I did them all at 30 to 40 hours, but children's pediatric life care plans can be very lengthy. So it all depends on medical records and also what the problem is, you know, and research and how long research takes. So if you've got 30,000 pages of medical records to go through, that's going to take some time. So I feel like pediatric life care plans can take anywhere from 50 to 90 hours, depending on how much time has passed. If you're looking back at 8 years of medical records, that's a lot of medical records. So I don't know if that helps any. Every situation is different. You'll think you'll have one that's fairly focused, but it turns into being very involved. Or you could get medical records that you're reviewing, and every one of those 30,000 pages is an individual physician's medical record. So you have to review every single item on it, you know. So
thank you. Here's another question. Do you always get to see and evaluate the patient?
No, which is very frustrating. And surprisingly, I've actually had plaintiff and defense cases that I haven't been able to see the patient. So, you know, usually plaintiff attorneys will allow you to evaluate the patient and meet with the family and do everything that you need to do. But if you're on the defense side, you're not given that access all the time. Very rarely are you get, let me clarify that. You're very rarely given that access. You always ask, and sometimes you are allowed to do that, but usually not. So in that case, you have to do the best you can with the videos that are provided, and with review of the medical records, and then talking with an expert. So if you are unable to communicate with the treating physicians or the patient family, then you have to talk to other experts who are experts in the area of the problem, you know, what the diagnosis is. It's always best if you can see the patient. It's always best. I would prefer that with every patient, but it's not always allowed.
All right, so we have time for a few more questions. If you have some more questions, feel free to use the Q&A functionality. You can also continue submitting questions via chat. I think there was one question that we might be able to provide some more clarity. So go ahead and we'll give it another minute or so to see if any more questions come in. Okay, I think we have been really clear. So I would like to just transition and say thank you to everyone who has joined the call today. And thank you to Cynthia for being such a spectacular presenter. Oh, we do have one more question. Let me go back before I close. So I think the question regarding government benefits, this question that the participant is saying some vendors provide a list of benefits. For example, a client is eligible for Medicaid, and Medicaid will cover gloves, I think, when they reach a certain age, or relevant in the state, right, state services, and they can allocate that cost and to arrive at the projected cost to the parents after backing out of government benefits. So I think this question is, we know that there's some federal benefits provided on, you know, when they're in school, and then as they age, once they possibly reach kind of that Medicaid, and, you know, 65 and up, there's more government benefits that may come in. Is that considered in the plan? And I hope I got that right to that participant.
I understand the question. No, it's not included in the plan, and there are actual legal rules where you cannot present that. Regardless of life care planning methodology, clearly states that you are not to consider any insurance or alternate means of payment for any of the services. They need to be reasonable and customary rates. So no, we don't do that. You could get disqualified if you did that. As an expert. And I believe, I'm not a legal person, but I believe you could get disqualified if you did that.
So again, if you have any more questions or comments, please feel free to use the chat functionality or the Q&A. Well, I'll continue standing by, but in the meantime, I would like to just remind you of the services that Medical and Life Care Consulting provides. We do provide comprehensive life care planning, medical chart review and chronologies, medical and life plan projections. Life care plan, this is not as comprehensive, but very similar to life care planning. There's Medicare set-aside allocations, legal nurse consulting, expert witness services, and then a newer product that we provide is a focused estimate of care. So it's looking at very specifically one injury and what would the care be for that specific injury, and not looking at all of the other body parts and present status that Cindy shared previously. Okay, it looks like we are done with questions. So again, I want to thank you for joining this presentation. We do hope that you found the information valuable. If you have any questions, our consultations are complimentary, and you can feel free to send us an email at info@medicalandlifecare.com, or visit our website. You can learn more about all of the services that we provide, And I think there's even a consultation request there that you can submit. And of course, our telephone number is mentioned here on the screen. Thank you everyone for your participation today. Have a great afternoon. Bye-bye.